A well differentiated squamous cell carcinoma, once again, well differentiated squamous cell carcinoma, you can see the infiltration. These are tongues of a squamoid island. These are the squamoid island. These are the squamoid epithelial cells, okay? And inside you can see this is the keratin pearl. This is the keratin pearl. So because it is so much well differentiated, you can appreciate the keratin pearls and the squamoid islands. It is a well differentiated squamous cell carcinoma. This is the very important diagram, as we can appreciate that grossly, as we can see, they have a classical nodular telangiectatic appearance. So the classic variety is the nodular one, and in the nodular one, the lesions is going very deep into the stroma, into the dermis, and as a result, they present with an elevated appearance. Now, as we can appreciate, if you can see, there are multiple tumor islands, as we can see, and at the periphery the nucleus is arranged in a palisading manner. As you can appreciate, at the periphery there the nucleus is arranged in a palisading manner, which is very characteristic for basal cell carcinoma. Also very important, this stroma or this dermal, if you see, it is separated from this tumor island by a space. This is basically a retraction artifact. We call it as a retraction artifact, also called as artifact of section or sectioning artifact. It is an artifact because of basically it is an artifact because of tissue processing. Individual tumor cells, if you see, they are uniform basaloid cells within the dermis, as we can appreciate. This is the layer of keratin that we can see, and you can see that in this keratin layer yet some parakeratosis or retention of the nucleus is there, okay? Very importantly, the lesion is starting out with dysplasia, hyperchromasia, pleomorphism in the lower layer. So basal cell atypia or dysplasia is associated along with marked hyperkeratosis. So there is an increased amount of keratin, and along with that, parakeratosis, that is retention of the nucleus in the upper layers, is also seen in this diagram. Okay, so the lesion is basically starting as a basal cell layer atypia or dysplasia involving the lower layer, that is the basal layer of the epidermis. Along with that, there is a hyperkeratosis and there is a parakeratosis, as we can appreciate in this diagram. Now this lesion, this dysplasia, okay, it starts at the basal layer, and as we can see in this diagram, it is extending into the full length thickness. Okay, so progression of full thickness atypia, the nuclear atypia that we see only in the basal layer over here, is now extending into the upper layers as well. So there is a full thickness atypia over here. Okay, and there might or might not be superficial epidermal maturation, and this full thickness atypia that we see, this is the in situ stage, and it is basically marking, okay, the development of squamous cell carcinoma in situ. So hello and welcome back. Today we are going to complete the remaining portion of yesterday's lecture. Today we are going to understand about squamous cell carcinoma and basal cell carcinoma. We are going to understand the pathogenesis, and before we start with the cancers, we are going to start with the precursor lesion. So actinic keratosis is regarded as a precursor of squamous cell carcinoma. It is usually occurring in sun damaged skin, and it is exhibiting hyperkeratosis. So I will show you with the help of a gross image, then you will be able to understand. So these tumors, if you see, they have a very high incidence, okay, in lightly pigmented individuals. So people who are having more melanin, they are protected from this condition. Now other risk factors include any exposure to ionizing radiation, industrial hydrocarbons, or arsenics. Now the lesions may show progressive worsening, which is characterized by dysplastic changes that might ultimately lead to cutaneous squamous cell carcinoma. Okay, and in this way they are very much analogous to the precursor lesions, that is the sin that we see in case of uterine cervix. Okay, so actinic keratosis can be regarded as a precursor of a squamous cell carcinoma of the skin, very much like the precursor lesions like the L cell and H cell that we see in case of squamous cell carcinoma of the uterine cervix. Clinically, actinic keratosis, they may regress or they may remain stable throughout life, but enough can transform to malignancy. Okay, so that is why local eradication is must for this particular lesion. So if a diagnosis of actinic keratosis is made, you should remove that lesion, because many cases are transforming into malignancy. So how you can remove it? You can just carry out a gentle curettage and freezing, or topical application of chemotherapeutic agents. Now, of interest, if you see, topical administration of a drug called as imiquimod or drug that activates the toll-like receptors, they can eradicate 50% of all these lesions. So there is a drug called as imiquimod that you can use. Okay, it is a drug that activates the toll-like receptor, which is a receptor of the innate immune system, and around 50% of 50% of actinic keratosis show response to this particular topical drug. Now, by stimulating the toll-like receptor signaling, imiquimod is activating the cutaneous innate immune system, and that is helping to eradicate this precancerous lesion, that is your actinic keratosis. So coming to the morphology of actinic keratosis, they are usually less than 1 centimeter in diameter. They are typically tan brown, red or skin colored, and they have a rough sandpaper-like consistency. Some lesions are going to produce so much of keratin that they will produce a cutaneous horn. That is why the term is actinic keratosis. So if you see over here, one of the gross image, as we can appreciate over here, excessive production of keratin producing a keratotic scale. In this lesion, it has produced what is called as a cutaneous horn. So this is basically very classical of actinic keratosis. Now, usually the most commonly affected areas are the sun exposed sites, that is the face, arms, dorsum of the hands. Now, the lips might also develop similar lesions, and in that situation we call it as actinic cheilitis. Okay. Now, cytological atypia that you will see in case of actinic keratosis is most commonly starting at the basal layers or in the lowermost areas of the epidermis, and it may be associated with hyperplasia of the basal cells. Or alternatively, in some areas you can see atrophy and thinning of the epidermis, sometimes you might see as well. Now, these atypical basal cells will show a pink or reddish cytoplasm, and this is called as dyskeratosis. You have to understand that keratinization is taking place in the superficial areas above the stratum granular layer, okay, above the granular cell layer. Now, if you see that below that layer, then it is called as dyskeratosis. So, keratinization below the stratum granular layer is called as dyskeratosis, as we have already mentioned in the previous lecture. Intercellular bridges are also present in contrast to basal cell carcinoma, in which they are not visible. So this way you can differentiate this actinic keratosis from the basal cell carcinoma. Now, the superficial dermis, if you see, it contains very thick bluish gray elastic fiber. So there is a lot of elastosis, and this occurs because of abnormal elastic fiber synthesis by sun damaged fibroblast. The stratum corneum is quite thick, and unlike the normal skin, the cells in this layer often retain their nucleus, so you might see parakeratosis. So from the previous lecture, I hope you remember what parakeratosis is. So parakeratosis is not very specific for actinic keratosis, but it is specific for any kind of an underlying pathology that might be there. If you can appreciate in this particular diagram, this is the layer of keratin that we can see, and you can see that in this keratin layer, yet some parakeratosis or retention of the nucleus is there. Okay. Very importantly, the lesion is starting out with dysplasia, hyperchromasia, pleomorphism in the lower layer. So basal cell atypia or dysplasia is associated along with marked hyperkeratosis. So there is an increased amount of keratin, and along with that, parakeratosis, that is retention of the nucleus in the upper layers, is also seen in this diagram. Okay, so the lesion is basically starting as a basal cell layer atypia or dysplasia involving the lower layer, that is the basal layer of the epidermis. Along with that, there is a hyperkeratosis and there is a parakeratosis, as we can appreciate in this diagram. Now, this lesion, this dysplasia, okay, it starts at the basal layer, and as we can see in this diagram, it is extending into the full length thickness. Okay, so progression of full thickness atypia, the nuclear atypia that we see only in the basal layer over here, is now extending into the upper layers as well. So there is a full thickness atypia over here. Okay, and there might or might not be superficial epidermal maturation, and this full thickness atypia that we see, this is the in situ stage, and it is basically marking, okay, the development of squamous cell carcinoma in situ. So it is that stage wherein the person is progressing towards in situ carcinoma, and later on will become invasive squamous cell carcinoma. So with this, we have completed actinic keratosis, which is one of the important precursor lesions to squamous cell carcinoma, wherein we have read in details about the pathogenesis regarding the same, and we have also read in details about how it is progressing towards squamous cell carcinoma, and what is the histological features, what are the risk factors as well. Coming to squamous cell carcinoma, it is the second most common tumor which is arising on the sun-exposed sites in older individuals, exceeded only by basal cell carcinoma. So basal cell carcinoma is the number one skin tumor. The second most common will become squamous cell carcinoma. Except for the lesions on the lower legs, these tumors, they have a very high incidence in case of men as compared to women, and invasive squamous cell carcinomas are usually discovered while they are small and resectable. So that is a good and fortunate piece of information. Now, less than 5% of these squamous cell carcinomas will metastasize to the regional lymph nodes. These lesions are generally deeply invasive and they involve the subcutaneous. Now, looking at the pathogenesis, if you see, the most important cause of cutaneous squamous cell carcinoma is the DNA damage, which is caused by exposure to the ultraviolet light, UV light. Especially, I'm not sure, but it is UVB light which is more important in the causation. The tumor incidence is proportional to the degree of lifetime exposure, sun exposure. So more is the sun exposure, more is the risk of development of cutaneous squamous cell carcinoma, because the UV light of the sun is basically causing DNA damage. A second important risk factor for the squamous cell carcinoma is immunosuppression. Most commonly, the chronic immunosuppression which occurs as a result of chemotherapy or organ transplantation. So whenever there is any organ transplantation, you are giving immunosuppressives, or a person is a cancer patient is getting chemotherapy, that is also leading to immunosuppression. So how immunosuppression is causing the cancer? It is contributing to carcinogenesis by reducing the host surveillance and increasing the susceptibility of the keratinocytes to infections and transformation by viruses. So in the chapter of neoplasia, there is a separate topic of microbial carcinogenesis, wherein we will learn how the microbes are leading to carcinogenesis. So once the immunity is less, any kind of infection or any kind of transformation by microbial agents like viruses, bacteria, okay, they might lead to transformation of the cells in such a way that might lead to carcinogenesis. For example, over here, especially the human papilloma virus infection, the subtypes 5 and 8, is implicated in the causation of cutaneous squamous cell carcinoma. Now, these same HPVs have also been implicated in tumors arising in patients with rare autosomal recessive condition like epidermodysplasia verruciformis, which is marked by a high susceptibility to cutaneous squamous cell carcinoma. In addition to its damaging effect on the DNA, the sunlight, through uncertain mechanism, they seem to cause a transient defect in the cutaneous innate immunity, okay, that may diminish the immune mediated elimination of the sun damaged cells. So that is also there, okay, that is also there. How sunlight, in addition to causing DNA damage, the sunlight is also altering the cutaneous innate immunity, leading to development of immune mediated elimination of the sun damaged cells, okay, that may diminish this immune mediated destruction. Now, other risk factors for squamous cell carcinoma includes industrial carcinogens like tar and oil, chronic ulcers and draining osteomyelitis, old burn scars, ingestions of arsenicals, ionizing radiation, and in the oral cavity, tobacco and betel nut chewing. So these are all the important risk factors, starting from sunlight, immunosuppression, HPV 5 and 8, along with that the sunlight altering the immunity. Other risk factors including the industrial carcinogens, chronic ulcers, draining osteomyelitis, old burn scars, ionizing radiations, tobacco, betel nut chewing. Now, most studies on the genetics of squamous cell carcinoma have focused on acquired defects in sporadic tumors and their precursors, that is the actinic keratosis, which we have just read about, and the relationship of these defects and sun exposure. So very importantly, we have seen that there is a very high incidence of TP53 mutation in actinic keratosis, okay. So there is a very high incidence of TP53 mutation in actinic keratosis. So it is suggesting that TP53 dysfunction is a very early event, okay, in the development of squamous cell carcinoma, and this is induced by the sunlight. Now, normally, as we all know, that the DNA damage by the ultraviolet light is sensed by certain checkpoint kinases like the ATM ATR. Okay, and very importantly, this ATM ATR is going to upregulate the expression and the stability of P53. Okay, so once any kind of DNA damage by the UV light occurs, it will be sensed by the ATM ATR, which is going to upregulate the expression of P53. What this P53 will do? This is going to arrest the cell in the G1 phase of the cell cycle. Okay, and it is going to check whether any kind of DNA repair can be carried out for the damaged for the damaged DNA. If it is possible, then the p53 will stop the cell cycle, it will repair the DNA, it will induce the DNA repair. Once the DNA repair occurs, it is successful, then the cell will go back into the cell cycle and will continue cell division. If that is not possible, if DNA repair is not possible, that means the damage is beyond repair, then that cell is going to undergo elimination, that is going to die by apoptosis. Okay, the p53 will induce apoptosis. So whenever any kind of cell damage is there, that will be sensed by the ATM-ATR, which will induce p53. If repair is successful, the cell will go back to the cell cycle. If the repair is not successful, then the cell is going to undergo cell death by apoptosis. Now this is why we are reading about the p53, because the p53 is very important and very protective. It is a tumor suppressor gene. So when the protective functions of p53 is lost, then the DNA damage induced by the UV light is far more likely to be repaired by error-prone mechanisms. And in that situation, cells with damaged DNA will be allowed to divide, and those particular cells with damaged DNA will be passed down to the daughter cells. So this is going to lay down a very fertile area for neogenesis or for neoplasia to occur. Okay, so the mutations that are seen in the TP53 are often occur at the pyrimidine dimers. Very important. So the TP53 mutations, so the mutations that are seen in TP53, they often occur at the pyrimidine dimers, indicating that they too are occurring because of damage caused by the UV light. Very importantly, UV light, usually they are causing mutations at the pyrimidine dimers, and those mutations which are occurring at the TP53 is also occurring at the pyrimidine dimers. So sunlight is the one which is inducing abnormalities in TP53, as well as they are causing mutations in the particular skin cells. Okay. Now one such particular condition is called as xeroderma pigmentosa, wherein the patients are having a very high susceptibility to squamous cell carcinoma. Now over here, the disorder occurs because of inherited mutations in the genes which are responsible for nucleotide excision repair pathway. Okay, now this particular repair pathway is very important for repairing the mutations occurring at the pyrimidine dimers. So any kind of sunlight induced mutation, which is basically in the form of abnormalities at the pyrimidine dimers, they are basically repaired by the nucleotide excision repair pathway. Now in individuals who are suffering from xeroderma pigmentosum, okay, they have inherited mutations in the genes which are involved in nucleotide excision repair, so they cannot repair the sunlight induced damage in the form of the pyrimidine dimers. Okay, so they cannot repair the pyrimidine dimers. Okay, so when this pathway is defective or error prone, okay, then what will happen, error prone pathways are going to take over. So there will be rapid accumulation of mutations at the pyrimidine dimers, and eventually this is going to be responsible for carcinogenesis. Now as with other forms of cancer, the cutaneous squamous cell carcinoma, they stem for multiple driver mutation. So the p53 mutation is just the starting point. Okay, in addition to the defects in p53, there will be increased RAS signaling, decreased NOTCH signaling. They are also common, and they contribute towards the process of squamous cell carcinoma. Now coming to the morphology of squamous cell carcinoma. Now remember, squamous cell carcinoma, now for example, this is the skin, this is the epidermis. So whatever cancer cells, when they are limited towards the basement membrane, okay, this is the basement membrane. So squamous cell carcinoma, which is limited in the epidermis, okay, which has not invaded through the basement membrane, okay, they are termed as in situ, called as in situ carcinoma. And these are grossly, they look like sharply defined red scaling plaques. So I'm not going to define what a scale is, what a plaque is. Already we have discussed the basic relevant anatomy of the skin. Now later on, what is going to happen, the cancer cells, they are going to invade the basement membrane, and they are going to invade the stroma. So more advanced invasive lesions, they will become nodular. So for example, initially, if this is the skin, the lesion, when it is in the in situ stage, they will just be like a plaque. This is a plaque. Later on, when the particular lesion is going to invade, then outside the lesion is going to become nodular. So remember, as the lesion is going to go down, they will become more nodular. Okay, so more advanced invasive lesions or invasive squamous cell carcinomas, they will have a nodular appearance. They will show variable keratin production, okay, and they might show ulceration as well. A very important thing over here is that unlike actinic keratosis and squamous cell carcinoma in situ, the cells with atypical hyperchromatic nucleus, they involve all levels of the epidermis, whereas in case of actinic keratosis, they are in various levels of maturation. Usually the ATP is starting from the basal layer in case of actinic keratosis, whereas in case of squamous cell carcinoma in situ, you will see that they will involve all layers of the epidermis. Now, invasive squamous cell carcinoma, they show variable degrees of differentiation. Okay, so some of the squamous cell carcinoma will show very well defined squamous pearls. So they will be well differentiated. Some of them might not show squamous pearls at all. They might not show keratinization at all. So they are poorly differentiated, and some of them will be in between the well and poorly differentiated. They are moderately differentiated squamous cell carcinoma. Okay, so let us see with the help of diagram. So this is one diagram. As we can see, this lesion over here, this is nodular. This has been elevated from the skin surface, and it is also ulcerated. Okay, so squamous cell carcinomas, usually they are nodular ulcerated lesion. Now if you appreciate over here, this is the normal skin. Now over here you can see how the lesion has invaded, okay, how it has invaded the stroma, how it has gone down and has caused invasion. So you can see the tongues of atypical squamous epithelium, they have transgressed, they have crossed the basement membrane, okay, and they have deeply invaded into the dermis over here. Okay, now very important, individual cells, if you see, they are having very large enlarged pleomorphic nucleus, and they might also have very prominent nucleoli, very important feature of squamous cell carcinoma. Now this, if you see, this is the early stage of squamous cell carcinoma, wherein you can see this is the basement membrane, and you can see islands of tumor cells have started, they have started to invade. This is the area of ulceration over here. Okay, so over here already the invasion has started. So this is basically the squamous cell carcinoma of usual type. You can see the branching lobules which are extending from an ulcerated surface in this lesion, and already the invasion can be seen over here. This is another lesion wherein we can see a very well defined, okay, keratin pearl. We can see the horn cyst or keratin pearl over here. Okay, this is squamous. This is a well differentiated wherein you can appreciate, okay, the squamoid differentiation along with the keratin pearl. This is again a well differentiated squamous cell carcinoma. Once again, well differentiated squamous cell carcinoma. You can see the infiltration. These are tongues of a squamoid island. These are the squamoid island. These are the squamoid epithelial cells. Okay, and inside you can see this is the keratin pearl. This is the keratin pearl. So because it is so much well differentiated, you can appreciate the keratin pearls and the squamoid island. It is a well differentiated squamous cell carcinoma. Now this is another lesion wherein you can see there is single cell infiltration. These are all pleomorphic tumor cells which has invaded. Okay, these are highly pleomorphic cells. Okay, we cannot see any kind of keratin pearl over here. So there is no differentiation. There is a very poorly differentiated, highly anaplastic and pleomorphic, poorly differentiated squamous cell carcinoma. So all of these cells have infiltrated the stroma. Okay, they are composed of highly pleomorphic cells without any obvious keratinization. So you cannot make out any obvious keratinization, and these are said to be poorly differentiated squamous cell carcinoma. So with this, we have completed the squamous cell carcinoma. We have discussed in details about the risk factors, the pathogenesis, and what is the classical morphology of squamous cell carcinoma. Now along with this, we will now complete the last leg of today's lecture, that is the basal cell carcinoma. Now, as the term suggests, it is a basal cell. Why it is called as basal cell carcinoma? Because the tumor is composed of cells resembling the basal layer. So these cells are very closely resembling the basal layer of the epidermis. So they are called as basal cell carcinoma. These cells are very small, round, okay, just like the basal cells of the epidermis. So basal cell carcinoma, as we know, it is the most common cutaneous carcinoma. It is a highly locally aggressive cutaneous tumor that is associated with mutations involving the hedgehog signaling pathway. And over here there is unregulated hedgehog signaling. Basal cell carcinoma, it is the most common invasive cancer in human beings, and they are slowly growing tumors and they rarely metastasize. The vast majority occurs at an early stage and therefore can be cured by local excision, just like squamous cell carcinoma. However, a small number of basal cell carcinomas are highly aggressive, locally aggressive, and they can potentially disfigure your face. And on rare occasion, metastasis to distant sites is also seen. So just like squamous cell carcinomas, they also occur in sun-exposed sites in lightly pigmented elderly adults. As with squamous cell carcinoma, the incidence of basal cell carcinoma is increased in the setting of immunosuppression and in disorders of DNA repair such as xeroderma pigmentosum. So we have already seen these points in squamous cell carcinoma. Now the pathogenesis is very, very important. So let me just first come into the pathogenesis, that what is happening over here. Remember, there is a particular gene over here, that is the PTCH gene, okay, which is involved in the pathogenesis of basal cell carcinoma. So what is happening here, we can see that in the normal cells, the PTCH gene is basically holding the SMO gene, okay, and it is regulating this gene. Only when SHH, that is the sonic hedgehog, is going to bind with the PTCH, that the SMO will become free, and this SMO is going to cause transcription, okay, of genes like the GL1, and ultimately there will be a cell growth and division. So what is very important, that there is a binding of the SHH that is causing release of the SMO from the PTCH, leading to the activation of GLI1, and then there is a cell division and proliferation. So there is a normal development and tissue homeostasis, and this is dependent on SHH. But in case of basal cell carcinoma, what is happening, that this PTCH is itself mutated, and as a result, in the absence of SHH, this SMO is becoming active. So in spite of absence of SHH, over here no SHH is present, yet what is happening, that over here there is the SMO in absence of SHH is causing activation of this transcription factor GLI1 and activation of gene expression and cell division. So over here in normal individuals, the process is dependent on SHH. So we called it as ligand dependent signal transduction, but as over here in basal cell carcinoma, there is a ligand independent signal transduction, as we can appreciate. So this is very important with regards to the basal cell carcinoma. I hope this pathogenesis is clear. Now, very important thing, that most of the basal cell carcinomas, they are having mutations that will lead to, unbridled or uncontrolled or unchecked hedgehog signaling. Now there is a particular syndrome which is associated with the basal cell carcinoma, that is called as nevoid basal cell carcinoma syndrome, also called as basal cell nevus or Golden syndrome. So it is an autosomal dominant disorder characterized by development of multiple basal cell carcinomas, often before the age of 20 years, which is accompanied by various other tumors, especially medulloblastomas and ovarian fibromas, odontogenic keratosis, pits of the palms and soles, and many other abnormalities. Now NBCCS is one of the number of cancer syndrome which is associated with skin manifestation. So there are many other types of syndromes like neurofibromatosis 1, neurofibromatosis 2. They also have skin manifestation. So there are number of other kinds of cancer syndrome also where there can be skin manifestation, but one which is very important with regards to basal cell carcinoma is your nevoid basal cell carcinoma syndrome, also called as Golden syndrome. The pathogenesis I have already discussed in detail with regards to the PTCH gene, so I am not discussing once again. Now mutations that activate the hedgehog signaling are also prevalent in sporadic basal cell carcinoma, and loss of function of the PTCH mutations are common, and about 1/3 of these mutations consist of C to T transitions that are hallmarks of the UV damage. Okay. Coming to the morphology of the basal cell carcinoma, they are usually presenting as a pearly papule, and they contain dilated subepidermal blood vessels. That means you will see that these are elevated lesions. They are papules, but they are less than 5 mm. They are very small, and on top of these lesions you will see dilated blood vessel, that is called as telangiectasias. So let me show you. This is the characteristic papule that you see. These are small areas, and on the surface you can see the dilated blood vessel. This is known as telangiectasia. This is a very classical feature of basal cell carcinoma. Usually remember, the BCC is occurring in the upper half of the face. Remember, it is occurring in the upper half, in the angle of the medial canthus and the nose, and this is the area that is classically involved in basal cell carcinoma. Now some of the basal cell carcinoma, they contain melanin, and superficially they might resemble melanomas or melanocytic nevus. Now advanced lesions, they might show ulceration, and extensive local invasion of the bone and facial sinuses may occur after many years of neglect or in unusually aggressive tumors. That is why the designation is rodent ulcers. So usually they might, usually advanced lesions, they might show ulceration. Usually they might, they might be progressive slowly, but sometimes over a long period of time a patient might not come with this disorder, and in a very end stage when the patient comes, or in some patient when the tumor is highly aggressive, okay, you will see that the tumor has completely locally destroyed the area, usually in the upper half of the face, okay, in the between the medial canthus and your nasal labial fold, okay, they might grow in that area. So sometimes they might be locally destructive. That is why they are also called as rodent ulcer. One very important variant of basal cell carcinoma is the superficial variety, which is presenting as a reddish lesion. They might present as a plaque that might resemble early forms of melanoma. So that is the superficial basal cell carcinoma, which is spreading along the surface. Now if you look at the microscopic examination, the tumor resembles the cells of the normal basal layers of the epidermis. They arise from the epidermis or the follicular epithelium, and they do not occur on the mucosal surface. Two important patterns are seen. One is the multifocal growth originating from the epidermis and sometimes extending over several square centimeters or more of the skin surface. So they are the multifocal superficial type. They are not extending deep. Okay, so they are just spreading over the skin surface, which is the superficial type. And another one is your nodular variety, which is growing downward. So any lesion which is growing downward into the skin will produce a nodular appearance. Okay, so they are growing downward deeply into the dermis as cords and islands of variably basophilic cells with hyperchromatic nucleus embedded in a mucinous matrix and often surrounded by many fibroblasts and lymphocytes. So you are having two types. One is the superficial variety, one is the nodular variety. Nodular variety characterized by downward extension of the tumor as cords and islands. Okay, and sometimes these cells also contain mucinous matrix, which I will show you. One very important point is that there is a classical palisading. That means if you look at that, if this is one tumor island, you will see at the end the tumor islands are going to show arrangement of the nucleus in the form of peripheral palisading. The cells at the periphery of the tumor cell island, they tends to be arranged radially with the long axis parallel in a parallel alignment. That is called as palisading. Okay, now there is a particular artifact during the tissue processing. What you will see that there are multiple islands, and these islands are separated from the stroma by a space, and this space is called as a retraction artifact or a separation artifact. Very important. So this is the very important diagram. As we can appreciate that grossly, as we can see, they have a classical nodular telangiectatic appearance. So the classic variety is the nodular one, and in the nodular one the lesions is going very deep into the stroma, into the dermis, and as a result they present with an elevated appearance. Now as we can appreciate, if you can see there are multiple tumor islands, as we can see, and at the periphery the nucleus is arranged in a palisading manner. As you can appreciate, at the periphery there the nucleus is arranged in a palisading manner, which is very characteristic for basal cell carcinoma. Also very important, this stroma or this dermal, if you see, it is separated from this tumor island by a space. This is basically a retraction artifact. We call it as a retraction artifact, also called as artifact of section or sectioning artifact. It is an artifact because of basically it is an artifact because of tissue processing. Individual tumor cells, if you see, they are uniform basaloid cells within the dermis, as we can appreciate. This is the nodular, this is the more common variety, that is the nodular variety comprising of basaloid cells. So you can see they have going deep into the dermis, so they are producing a nodule. This is the nodular, the more common variety. Islands of basaloid cells can be seen. Now this is again, you can see what is very important. This is a classical retraction artifact, as we can appreciate, which is occurring because of tissue processing. This is another image wherein you can see that within this we are having certain mucinous islands also. So mucinous zones are present in the stroma of this lesion. You can see the mucinous lesions also present. Now this is the second variety, that is the superficial variety, wherein the islands of tumor cells, they are basically growing along the skin surface. Okay, so this is the bud-like nest of basaloid cells connect to the epidermis across a broad front, across a superficial spreading variety. Now this is another variant of basal cell carcinoma, wherein you can see a lot of sclerosis, which is called as a morphic type. Okay, they have a desmoplastic stroma. So with this we have completed the basal cell carcinoma as well. I hope you all have enjoyed this particular lecture. Thank you very much for watching.